First ask the first speaker, Dr. Vinod Kumar, Additional Professor of Ophthalmology at Dr. RP Center for Ophthalmic Sciences, All India Institute of Medical Sciences, to give his first talk on embryology of the fovea and etiopathogenesis of macular.
Good morning, everyone. At the outset, I would like to thank Dr. Dhanshri Ratra and the whole team of SN for this invite and for wonderful hospitality. So the topic allotted to me is embryology of fovea and etiopathogenesis of macular hole. So since we are starting with very basics, so I'll stick to the basics. We all know, just to recapitulate, fovea is the highly specialized area in the center of the macula. It constitutes only 0.02% of the human retina, but 50% of the visual cortex is used up in the processing of information from fovea. It is characterized by central foveal avascular zone, absent inner retinal layers, high cone density, and absence of rods. So is this the how fovea begins with? I think not, because we know that embryology of fovea is a very complex and a long process. It starts as early as in the fetal gestation area. So it starts around mid-gestation, extends up to 13 years of age, and in fact, some people believe it keeps on going later on as well. So earliest identification of the fovea can be done around fetal week 11, and at that time, what we can see is a single layer of cones, as you can see here in this picture on your left side. On your right side, the topmost picture on the left side, so there is single layer of cones with all the inner layers intact. But this is not what happens subsequently. Three crucial events happen in the process of maturity. So first thing what happens is the centrifugal displacement of the inner retinal layers to form the foveal depression. Now this starts somewhere around 24 to 26 weeks of gestation, and it reaches completion around 15 months postpartum. So as you can see, this is a schematic diagram. There is a bulge initially during the fetal period, and that is because of the inner retinal layers heaped up. But subsequently, these inner retinal layers, they migrate centrifugally outwards to lead to the formation of a foveal pit. Second process that happens is centripetal or central migration of the cones. As again you can see, there is a single layer of cones, but subsequently all the cones, they migrate towards the center, leading to the higher density of the cones. And third thing which happens in the fovea is packing of the cones. And this packing of cones may extend even after 45 months of age. So when the cones move centripetally towards the pit center, it leads to central crowding of the cones. The outer nuclear layer of the fovea becomes very thickened. The cones, because they have to pack together, they become elongated, and there is a reduction in the size of the foveal cones. As I mentioned, cone packing occurs after birth and is completed by 4 to 6 years of age, and that is the reason why adult cone density reaches almost 20 to 30 times higher than the foveal cone density, and the diameter of the cones reduces. The same thing happens with rods as well. We tend to believe that rods also migrate centrifugally, but it is the opposite. The rod-free zone is much larger at birth, and it tends to shrink by 45 months of age. That indicates that there is centripetal migration of both rods as well as cones. Now, all the findings I mentioned till now were based on histological studies, which were based on lesser numbers of eyes, and we had confounders like tissue shrinkage and mechanical distortion. But subsequent with the onset of OCT, most of the OCT studies have supported these findings of histological studies. Now I'll come to the second part, that is etiopathogenesis of macular hole. There are several pathogenesis theories which had been given before the onset of the conventional classification given by Sir Gass. So these were traumatic, cystoid degeneration, vascular theory, vitreous theory, and involutional macular thinning. We know that in today's scenario, that vitreous traction is the major reason why macular hole forms, but some of these may still hold value in other atypical macular holes. So we are all aware of this gas classification based on biomicroscopy, and what gas-based his theory was on the predominantly tangential vitreous traction. But nowadays, we know with the onset of OCT that it is the anterior-posterior traction which is important in the formation of macular hole, and subsequently it is the tangential traction which is important in the enlargement of the macular hole. So according to the according to the OCT classification, we start with anterior-posterior traction because of vitreomacular traction. It leads to formation of cyst inside the fovea, which subsequently extends to the outer retina, leading to a yellow ring of gas classification, and this outer hole may subsequently extend and lead to formation of occult hole. Once there is deroofing of this cyst and the vitreous is still attached to one edge of the macular hole, we call it stage 2, or this is the first full thickness macular hole in the evolution of macular hole. When the PVD is complete at the fovea, but not at the disc, this is stage 3 macular hole, and stage 4 macular hole is when you have complete PVD with vitreous detaching from the optic disc, leading to the visibility of V's ring. Now, as I mentioned, this vitreomacular traction may or may not be associated with epiretinal membrane, and anterior-posterior traction is most important in the initial formation of macular hole. Nowadays, we follow international VMTS system for classification, and according to these, the small size hole constitute less than 250 microns, medium size holes 250 to 400 microns, and anything which is more than 400 microns constitutes a large macular hole. This may or may not be associated with VMT. Now, I was wondering why these topics, two topics have been combined, so I thought I'll try to correlate. So, at the outside, if you look casually, they do not appear to be connected, the embryology of fovea and etiopathogenesis of macular hole, because vitreous plays an important role. But we do know that once we do the surgery for macular hole, there are changes which are continuously happening in the outer retina. So we have all come across cases where initially there is outer lucences, we call them outer lucences or void, and subsequently we have seen that ELM and at the last EZ tends to become continuous. So this we have all witnessed. So I thought at a moment that foveal embryology may once again be involved in the healing of macular holes. So I came across a very interesting paper by Dr. Spade in very recently in Retina. So what Dr. Spade did is he evaluated serial OCTs after the macular hole surgery, and he calculated the inter-inner nuclear distance and the outer nuclear layer thickness after the macular hole study. And he found that while the inter-inner nuclear distance increased, that is, there is centrifugal migration of the inner retinal layers, there is centripetal migration of the photoreceptors, thereby leading to the thickening of the outer nuclear layer. So these suggest that healing mechanisms after macular hole repeat the process of foveation which happens during the fetal process. So these are some of the pictures from Dr. Spade's paper, and as I have shown, the same things happen. The inner nuclear layers, they travel outwards, and the outer layers travel centripetally. But this may not happen in all the conditions as we go through. So to conclude, development of fovea is a long and complex process. It starts in utero and goes on until few years after birth. Vitreous plays a major role in the pathogenesis of macular hole, and the process of foveal development seems to happen once again during the remodeling of retina after macular hole surgery. Thank you very much.